Hello and welcome to our podcast, Dysphagia Matters. I'm Jule and with me is my friend Julia.
Hi everyone. We're really excited to share this episode about pharyngeal electrical stimulation with you today. It seems to be a really hot topic at the moment. So just last month, we attended the conference of the European Society for Swallowing Disorders, ESSD, and we had the chance to listen to quite a lot of talks about pharyngeal electrical stimulation, or short PES.
Yes, and we're really happy to have had the chance to talk to Shaheen Hamdy, Professor of Neurogastroenterology at the University of Manchester in the UK. He was one of the first to conduct research on this topic and is also the co-founder and chief scientific officer at Phagenesis, which is the company behind Phagenics, a treatment for dysphagia using pharyngeal electrical stimulation.
So this approach is one of the most promising advancements in the field of dysphagia treatment at the moment, and it feels like it might be a game changer in our field. So we hope you enjoy listening.
Hello, Shaheen, and welcome to the Dysphagia Matters podcast. Thank you for taking the time to talk to us about the pharyngeal electrical stimulation today.
Thanks for the invitation. Looking forward to our discussions this morning.
Yes, thanks so much. So, Shaheen, you have been one of the first, if not the first, to conduct research on pharyngeal electrical stimulation, short PES. Can you tell us about the origins and development of PES?
The background to this goes back, best part of 25 years. It actually work that was done during my PhD. And we were really interested more in the physiology of stimulation of the pharynx, on how the sort of central pathways between the brain and the swallowing system interact. So the original idea was that we could potentially use stimulation to modify the pathway. And that was because prior research we had done has suggested that if you stimulate cranial nerves, you could enhance the pathway. So the issue was then, if you can stimulate cranial nerves to enhance the pathway, what about if you stimulated the pharynx itself? So we started looking at human models, mainly initially in healthy volunteers, and we were using a catheter at the time that recorded EMG from the pharynx. So essentially, we instead of recording, we decided to hook it up to an electrical stimulator box and deliver some stimulation. At the time, we chose a very sort of generic frequency of stimulation. At that stage, it was 10 hertz. And we looked at the changes in the brain following a 10-minute burst of stimulation to the pharynx at a just perceived level of stimulation, so the subject could just about feel it. And what we found was that after 10 minutes, and when we made some recordings in the brain, in the swallowing areas controlling the pharynx, the area that was representing the pharynx in the brain was actually increasing. And the area that was in the esophagus seemed to decrease slightly, which is quite interesting. And we called that neuroplasticity, and we published that in Nature Neuroscience. And then that started to lead on to loads of additional questions. What is the right frequency? What is the right dosage? How do you deliver this kind of thing? Could it be used therapeutically? So we then went on and did a whole load of additional studies, essentially, again, mainly in healthy subjects, looking at the frequency, the duration, the optimal timings. And that work suggested that 5 hertz was better than 10 hertz, and 10 minutes was just as good as 20 minutes. And the duration of the effect would last to a single dose at least 2 hours. And that then led into a small clinical trial to look at short-term effects in stroke patients. And we basically delivered that combination in a small series of stroke patients who had dysphagia and evidence for aspiration on their videofluoroscopy. And we found there were some favorable changes. So, of course, that then started to make us think, could we deliver this as a proper treatment? We then went on to do some dose response work. So this is where we look at, what type of dose would work. Do you just give it once a day for 3 days, or twice a day for 5 days, or 3 times a day for 5? There were a whole load of different questions. That work took a long time to do because it was quite complex. It resulted in an initial prescription, which was once a day for 3 days, which seemed to be as good as anything else. That led on to some further small-scale trials where we used that dose in another 30 or so patients and looked at 2-week outcomes and found that there were some favorable outcomes. In particular, aspiration was reduced, swallowing function was improved. So then, back in those days, as a university academic, I realized there was an opportunity to expand this into something that could be used actually, in general clinical care. And the only way to do that was to go through a kind of commercialization process. So the research then led on to the development of a company called Pharyngeal. And of course, since then, it's then become a treatment called Pharygenics. So that's the pathway. That took about 20 years. Pharyngeal was actually established in 2007. So it's then taken another best part of 20 years to get it to this stage. So a very long process. And my hair has gone completely grey in that period of time. So, the aging process has not been particularly good for me. But we have now got to a stage where, the treatment is available.
Yeah, thanks so much. That's really a huge amount of work. And yeah, it's impressive to see for how long you've been doing this research on this topic and how it's emerging. And I think this is really important for so many fields in dysphagia treatment. So it's great to have at least one tool that has lots of research on it. So you've already mentioned Pharygenics and Pharyngenesis. Could you maybe just, as a disclosure to our listeners, shortly explain what your role is in the company?
Yes, so when the company was established, which was in 2007, myself and a colleague of mine who was from the university IP, which is Intellectual Property Limited Department, Conor Mulrooney, we established the company as founders. And then as part of that process, we took on roles. So I took on the role of Chief Scientific Officer. I then went on to the board and acted as a board director until this year, actually, when I've now stepped down from the board because of the changes in the funding. So at the moment, my main role is as Chief Scientific Officer of the company.
Okay, thank you. And so that's been the whole development and journey of PES, but there seems to be some confusion around neuromuscular electrical stimulation, short NMES, and PES. Could you maybe help us differentiate what is what? So what is neuromuscular electrical stimulation and how does it differ from pharyngeal electrical stimulation?
Yes, that's a pretty important point, and it's a question that we get asked a lot, actually, because of the slight confusion over what and how these two treatments deliver their therapy. So neuromuscular electrostimulation, and I caveat this because I'm not involved in neuromuscular electrostimulation research or in any of the delivery of the companies, for example, VitalStim or Amcare. They're probably the experts. But my understanding is obviously that neuromuscular electrostimulation is essentially a peripheral stimulation device. What it does is apply peripheral electrodes to the sort of neck area and submental area, and it delivers a current to these areas at a fairly high frequency generally, using certain configurations that have been established to induce muscular contractility. So at the higher dose, it causes muscular contraction. At the lower dose, you can deliver it, I think, at a sensory level as well. The big difference between neuromuscular electrical stimulation and pharyngeal electrical stimulation is obviously the fact that pharyngeal electrical stimulation is intraluminal. It stimulates the pharyngeal afferents, so it's a sensory stimulation predominantly. It is designed to activate the pathways to increase changes in the brain. In other words, inducing excitability in the brain that we think is good for recovery, particularly in neurological disorders. And it's delivered via a catheter. And we use a lower frequency, 5 hertz. Neuromuscular stimulation doesn't or is not known to induce those brain changes directly. It probably works via a muscle re-education process. So it is designed to predominantly change muscular function and obviously works entirely, as I understand things, peripherally to try and improve muscular control. So there are pretty significant differences, and we would never call pharyngeal electrical stimulation a neuromuscular electrical stimulation system. It doesn't affect the muscles in a direct way. It's inducing changes centrally to produce the effects peripherally. And obviously there's a lot of controversy about why one would work better than the other. And there are lots of trials in both techniques. But obviously, the advantage of pharyngeal electrical stimulation is that, in particular, it can induce swallowing responses. Neuromuscular stimulation is not really designed to actually induce swallowing. It has to be done in combination with the subject delivering or being asked to do swallowing exercises. So with pharyngeal electrical stimulation, that is not necessary. The stimulation itself, because it's activating the relevant afferents, will induce a swallow response, a reflexive swallow response. But of course, the main effect is the central effect, which is what we believe to be the most important aspect for the recovery.
Thank you for that explanation. I think that's important to keep in mind during the rest of our episode. You've already slightly touched on the administration of PES. Can you again describe what is actually happening and what do you do during the administration?
Okay, so to remind the listeners that the stimulation is obviously delivered intraluminally, in other words, it's delivered into the pharyngeal mucosa via a catheter, which is placed by a clinician either through the nose or through the mouth, usually through the nose, similar to how you'd pass a nasogastric tube. The catheter tends to be about the same size and actually has the function of being able to deliver food as well to the stomach. But its main role is to deliver electrodes positioned in the pharynx, which are housed by the catheter. So the catheter is passed, the position of those electrodes is confirmed using markers and distances in order to establish that you're likely to be in the pharyngeal area. The catheter is then connected to what's called a base station, which is a electrical stimulation box, which delivers the current in an effective, safe way. And then through a short period of titration, the subject who's being stimulated is asked to tell the operator when they can just perceive the stimulation and when they feel it's at the most maximal tolerated level that they can take. The box then calculates a dose, an intensity, based on those two parameters. It's roughly about 75% of the difference. And then the stimulation is commenced using the box, which is programmable. You would normally set it to deliver for 10 minutes of stimulation at that setting. As I said, it's 5 hertz. And usually that would be delivered on a daily basis, once a day for up to 6 days. Typically, the patient will be given 3 days of treatment, and then a review might take place. And if their swallowing is still not optimally improved, you give another 3 days of treatment. So a total of 6 treatments. It can be delivered by, as I said, clinicians, therapists who are able to pass catheters or to do fees. They can be placed using fees if necessary. And our experience is that speech therapists, research nurses, and obviously medics can all deliver this treatment.
Okay, and the way you've just explained it, is this a standardized protocol that one should use at least to begin with, and then, like you said, reevaluate if it was efficient and effective or if further sessions are needed?
I mean, typically that's what we would recommend, that after 3 days of treatment, a review can take place to establish the patient's swallowing function has improved, and that can be done clinically or instrumentally. If at the end of that 3-day treatment, the patient is showing signs of improvement, but the clinician feels there's more benefit to be gained, then it's quite reasonable to deliver another 3 sessions. Arguably, some have just gone straight for 6 sessions, maybe with somebody who's got more resistant dysphagia. As far as the treatment is concerned, there's no reason that you can't do that. But some patients do respond after 3 sessions. And so we usually recommend a review after 3 sessions and then a further delivery as necessary. But the maximum dose that it's licensed for at the moment is 6 sessions.
Okay, yeah, I was just gonna ask that.
You can theoretically deliver more treatments, but you'd have to remove the catheter and replace it with a new catheter, because the catheter won't allow you to treat for multiple sessions for a number of reasons. And so there are patients who have had 6 sessions and they've shown improvement, and then it's been felt that perhaps they might benefit from a further course, and so they may have had a reinsertion of a catheter and some further treatments.
And those 3 or 6 sessions, are they always on consecutive days?
Usually, we don't particularly recommend delaying individual sessions for more than 24 hours. You can, I think, extend to, say, 36 hours, and there may be reasons. I think if you go beyond a couple of days, you should probably restart the treatment completely from the beginning. The system allows you to do that. So, for example, you start the treatment and then the patient becomes unwell for another reason. You can stop the treatment. They can be treated for whatever condition they've got, and then you can restart. But I would recommend a full restart from the beginning, if it's more than sort of 36 hours.
Okay, and you've said that to get the setting, the patient is giving feedback on what he or she is feeling. Can you also administer it in people who aren't awake or can't communicate?
You can definitely administer it in patients who can't communicate. An unconscious patient, I think you probably wait until the patient has some level of consciousness before you deliver the treatment. Although we're aware that actually there are patients who can even respond when they're semi-conscious or have low levels of consciousness. Because when you deliver the treatment, not only does the patient feel the stimulation and can either indicate that they can feel it or they can't feel it. So they can use, their hand, or we even have communication boards for people who've got dysphasia. But in addition to that, where there's some level of conscious reduction, when we set the stimulation to higher levels, patient also can experience some discomfort, and they can display that in terms of sort of automotive responsives as well. And so when we see if a patient isn't communicating well, but we see that they show sort of signs that they are swallowing rapidly and look like they are uncomfortable, then that can be used as a method for determining the upper level. And then you can sort of determine what sort of intensity. So most patients can be treated even if they can't communicate. But I think if they're completely unconscious, for example, in a coma, I think it would be difficult to deliver the treatment without getting some indication of what the patient is experiencing. I mean, there are some studies, these are all anecdotal studies, which have even suggested that when you start stimulating, you see a change in the conscious level. The conscious level actually increases. So patients become more responsive. The mechanism for that we don't fully understand. It seems to have an awakening effect. And there are some clinicians in Europe who have noticed this, and are even thinking about using this as a way of also improving conscious level. But that's completely separate from the main method that we use the treatment.
Okay, great. So now that we know how PES is administered, what do we know, or what do you know about how PES theoretically improves swallowing function?
Yeah, so that goes back a little bit to the early studies where we were able to demonstrate both in healthy subjects and in patients that if you deliver this treatment, you can see measurable changes in the cortical areas involved in swallowing. So we were able to map out the fact that after a treatment dose in both a healthy subject and in the stroke patient, that the areas that seem to control swallowing had increased in size. We think that increase in size is linked to what we call, as I said, cortical plasticity, neuroplasticity, and it's well recognized that in stroke recovery, this process of plasticity is critically important for the recovery to take place. We think that in stroke patients, because you have a bilateral system, but it's asymmetric, in other words, it's not the same between the two sides, it's probably slightly lateralized, that in a stroke patient with a lesion to one side, if you can induce those plasticity changes in the undamaged side, which we think is involved in the recovery, if you can induce those changes experimentally or artificially, you can perhaps accelerate the recovery. And so pharyngeal stimulation, based on our studies and in other studies, it primarily seems to change those centers, more so on the undamaged side of the brain. And that change accelerates the recovery following neurological disease, particularly stroke, but possibly other neurological diseases as well. We think there's also some potential peripheral effects. So some work that's been done in Munster has also shown that if you deliver stimulation to both healthy subjects and patients, there are changes in salivary substance P. Substance P is a excitatory neurotransmitter, which also has effects on sensitivity in the pharynx and in the larynx. And we think that possibly some of the effects that we see may also be related to the release of substance P in the pharynx and larynx, which helps to increase sensitivity in the throat, which we know is important for swallowing, improvement of swallowing recovery. Beyond that, there may be some changes that occur in the brainstem, but they're very difficult to measure. And we think that also adjunctive treatments may be useful. So pharyngeal stimulation is delivered usually in addition to any therapies that the clinician wants to deliver to the patient. So we do not suggest that this is the sole treatment. If the patient is already receiving physical therapy, behavioral maneuvers, maybe other forms of intervention to try and improve the swallow, then pharyngeal stimulation is adjunctive and we think probably additive. But it can be delivered on its own in patients who are unable to, for example, follow behavioral maneuvers, which can be difficult. The treatment can still be delivered, and the results suggest that a large proportion of these patients do seem to get benefit.
Thank you for that explanation. I always like to ask, I call them journey questions. So could you maybe take us on a journey and give us a step-by-step overview of what happens? So we've got the catheter induced, it touches the pharyngeal wall, and the electrical stimulus meets the mucosa. What is happening?
So we think that when the electrodes are seated in the right position, which is sort of mid-pharyngeal area, is probably around the level of the epiglottis, those catheter electrodes are touching the posterior pharyngeal wall around that area. And so when you're delivering stimulation at 5 hertz, a current is running through those electrodes and is delivering a electrical energy directly to the pharyngeal mucosa. It's set at a level which is really mainly activating the afferent nerves in the pharynx, as opposed to being set at a level which might induce any sort of tissue damage. And actually, we've studied this in some detail and found no evidence that the currents that are delivered cause any tissue damage as such. So it seems to be pretty safe. That stimulation of the nerves, and bear in mind that electrical energy is quite generic. In other words, it stimulates all the nerves. And so you're stimulating a lot of nerves in that area. We think we're stimulating the superior laryngeal nerve, glossopharyngeal nerve, possibly accessory branch, whichever nerves the electrodes are in contact with, it will stimulate. And those activations of those nerves are then obviously sending impulses from the periphery to the central nervous system, going through probably, I'm going to get a bit technical here, the tractus of the nucleus solitarius, which is a relay station in the brainstem, and then going up into, we think, to the cortex, where it then induces its effects. And of course, that effect is due to what we call facilitation. So you're continually sending a pulse up, and bear in mind that 5 hertz means it's every 200 milliseconds. And that pulse direction is enough to cause some form of what we call long-term potentiation, or LTP, and that seems to be sustainable. And by inducing that central change, the brain is changing, and the patient then is hopefully recovering because they're gaining more control. So it's an activation pathway, peripherally, energy driven through electrical stimulation, through the peripheral nerves, mainly the sensory nerves. There may be some motor nerves involved as well, mainly sensory nerves, to the brainstem and up to the cortex.
So, because now this was the efferent way, how do you think then the motor response is improving through that efferent stimulation?
Obviously, you can imagine if there's a stroke, you've damaged that central pathway, that cortical pathway predominantly, or subcortical pathway. So the muscles in the pharynx and larynx are generally intact. The problem is that the pathway has been disrupted. It's been damaged. And so because of that damage, the pathway can no longer function correctly. If you can enhance that pathway or start to recruit new pathways, which are still in the system but are usually redundant, because normally in health we don't need them, then you can start to re-engage that muscular system again. So we think that pharyngeal stimulation is working predominantly because we're re-engaging or restoring those natural pathways that already exist. And so by restoring those natural pathways, you can reactivate the main mechanism, both at the central level and then, of course, at the peripheral level. So it's much more about restoration of pathways. Some of them may be redundant. And as I said earlier, if you recall, we think that the arrangement of the cortical pathways involved in swallowing are asymmetric. So we have bilateral pathways, but one side seems to take most of its control. The other side is there, probably has some function, but is not being used particularly strongly. If that strong pathway is damaged, you can work on the weak pathway and try and increase that. And so that restoration of these pathways, and particularly the undamaged pathway, is then able to recruit the relevant areas of cortex that can then activate the swallowing system again. So, in the literature for pharyngeal stimulation, we talk about restoration as opposed to muscle training.
Looking at the research again, you've already touched on that. And I think, as far as I understand it, it sounds very promising. So research is showing positive effects of PES for people with dysphagia. Are there any studies that show maybe conflicting results or negative results?
I mean, the vast majority of studies in the main have been positive, which is great. And I'd highlight the fast track study and Theta, which is an open label registry study. And they were quite large studies, which showed that you could treat both severe stroke with tracheotomy and also a number of other conditions. In the early days, when we were looking at this, after we completed some phase 2 work, we did do one phase 3 study, which was known as STEPS. And STEPS was done mainly in the UK with a couple of European centres. In that study, the results were what we call neutral. There wasn't a big difference between the two patient groups. And we did investigate that in great detail to work out why. It became clear that there was suboptimal stimulation of the active group. There were overstimulation of the sham group because the sham group did receive stimulation in the form of the dosing. They didn't receive the full 10 minutes, but they were given dosing. And if you were doing the dosing quite slowly, patients were receiving 2-3 minutes of stimulation. So there were a lot of caveats to that study, which led to a lot of learning, actually, in terms of understanding that, you've got to deliver the treatment at the relevant dose. And in our experience, we like to see the intensity to be as high as possible. We use milliamps, and typically patients should be getting sort of 20, 30 milliamps of stimulation. If it's really low, you're not going to get the benefit, I don't think. In addition to that, we realized that when you do trials, you have to make sure that the patient population, the non-active arm, in other words, the sham arm, is not receiving treatment, which is then going to cause problems with analysis. So that was a very useful process for us and has led on to changes in trial design and also different populations being studied. So that particular study was a neutral study. But actually, if you take all of the studies together and include that neutral study and put them into a meta-analysis, you still see that the treatment produces a more favorable outcome than the sham. And we and other groups have published on this as well. Sometimes it's good to kind of get studies where you are unsure of the effect because it makes you really carefully reevaluate what is being delivered. And I think in retrospect, actually having that study has been extremely helpful in terms of considering how the treatment can be delivered to future populations.
Yes, absolutely. And probably the wording negative results wasn't the best. So like you said, we can always learn so much, and maybe it's just not what we anticipated as an outcome, but it was different. Like you said, the sham group had improved more than you probably were anticipating. But based on this, yeah, we can learn so much.
You've already mentioned that you conducted a meta-analysis, and we will put it in the show notes together with other recent studies. Are there any active studies at the moment?
There's a current large clinical trial going on between the UK and some European centres, predominantly a UK study, which is to recruit 800 patients into an active and sham arm of stimulation in stroke, led by Professor Philip Bath. That is called FEAST, spelled PHEST, or PHEAST, I should say, not ET. And that is due to probably close and then port. My guess is the end of 2025 or maybe early 2026, depending on the recruitment. So there's increasing data, and we're seeing, in addition to these already published studies, what we call investigator-initiated studies, where investigators are just interested in whether the treatment is worth trying in different populations, and those are popping up all the time.
Okay. Did you say 800, so 800?
Yes.
Wow.
Yeah. Yeah. So we've had about 2 years of recruitment. They're up to around about 260, 270 patients, which
Wow.
is already one of the largest studies in dysphagia research. So it's a lot of patients.
It is.
We'll see what happens. The number of centers that are being brought into the study keep on increasing, so I expect it to continue that way, and so we might see a further acceleration.
Yeah, great. That's impressive. You've already touched on a few patient populations, especially where research is being conducted in. So, like post-stroke is the largest population. Are there any other specific conditions or types of dysphagia where PES has shown particular promise?
Hmm. Yeah, that's a good question. I mean, if you look at that study I mentioned that was published in eClinical Medicine, which was called FADA, the FADA study, there were a number of populations that were studied. So there was stroke, both stroke who had tracheotomy and stroke who did not have tracheotomy. But they also looked at traumatic brain injury. And there's also been another group which we've called sort of intensive care critical illness polyneuropathy. So what that study found was that the stroke populations obviously improved, but also there was some evidence that traumatic brain injury related dysphagia was also alterable in a positive way. The size of the effect was slightly less than in the stroke, but it was demonstrable. In critical illness neuropathy, in patients who, for example, have had long-term intubation, there is some quite good quality work that suggests that patients who, for example, are on intensive care, who have had tracheotomy for other reasons, but it's been difficult to extubate them because, for example, they've got this CIP, critical illness and polyneuropathy, or other reasons, that pharyngeal stimulation is being used consistently to help the extubation process with some success. And so not just in stroke, but in patients who've got other conditions, including, for example, cardiovascular and respiratory conditions as well. One of my colleagues who's based in Withenshaw Hospital, which is a hospital down the road from where I work, Sarah Wallace, has been using this quite a lot in their department, in their intensive care group, and seems to have found it to be extremely helpful, as there is very few treatments to help with tracheotomy removal in these patients who often are clearly dysphagic. We have less data in some other neurological conditions, such as motor neuron disease and Parkinson's disease. Of course, these are chronic progressive disorders. The mechanism of recovery is less clear because I think the whole process of recovery and neuroplasticity is much less prominent in such conditions. I think the jury is unclear in those groups, and we need more studies to be able to establish what is the effects of pharyngeal stimulation in Parkinson's or motor neuron disease. Some studies have been done in other conditions like Guillain-Barré syndrome and in some additional neuropathy type patients with interesting results, actually, usually positive. But again, we haven't got the clinical trials to kind of know exactly how much benefit you're going to get from these things. Of course, the pharyngeal stimulation system, Phygenics, is licensed in Europe to be used in neurogenic dysphagia. In the US, we have FDA approval to treat severe stroke. Slightly different indications, but it's one of the reasons why we're seeing in Europe quite a few studies and observational pieces of work where the clinicians have decided to try it in different populations. And talking to my colleagues who are working in places like Austria and Germany, some results that look promising.
And are there also any contraindications for specific patient populations?
There are some general contraindications. So, for example, obviously, if it's not possible to pass the catheter because there's maybe nasal deformity or a throat-related issue, then that's a contraindication. We also would suggest being cautious in patients who've got severe respiratory conditions. So if they've got, for example, severe COPD or something that would compromise their airway, then obviously passing a catheter may be more difficult. And so we caution against that. We don't have clinical license for the treatment to be used in children and pregnant women. This is very common, unfortunately, because you just don't have the data. And then implantable electrical devices, for example, deep brain stimulators and cardiac pacemakers, even though we have no evidence that there's any direct or indirect effects of the pharyngeal stimulation on these devices, we would caution use in those populations. And finally, because the electrodes are currently not MR compatible, you advise not to put the patient through an MRI scan with the catheter in place. And we have no information on the effects of defibrillation if the catheter is in place and have a defibrillator. So there's only a few, and it's very limited, but they are listed in the information booklet which comes with the device.
Before, you've already mentioned a discomfort as a potential side effect or adverse event. Are there any other side effects that have been observed in the studies?
The good news is that it's been shown to be extremely safe, and so serious adverse events have not been demonstrated in over, I think now we're probably talking about 800 clinical study patients and 5,000 real world. We don't see any serious adverse events. In terms of adverse events which have been reported, these generally link to either poor position of the catheter electrodes or potentially patients who are compromised in terms of their kind of general condition. So if somebody's malnourished, for example, severely malnourished, they may be more sensitive because of tissue-related issues. But we've seen, for example, some sort of jaw chattering occasionally, mainly because the catheter has been put too high. Hypersalivation, so sometimes patients are salivating more, which is actually a good indication the stimulation is probably doing something. Beyond that, some have described sort of sensory issues around the face, but these are all usually easily restored by either repositioning the catheter or reducing the intensity.
Let's move on from the research to the clinical implementation. What are the practical considerations for implementing PES in a clinical setting? What are your experiences or recommendations as well?
Ultimately, this is about clinicians feeling confident that they want to try the treatment. Where that is the case, obviously, we have a team within Pharyngeal who are able to assist in that process. So implementation is really about engagement. Once it's felt that their patient population might benefit, we would recommend that the clinicians approach relevant teams around the areas, whether it be Europe or North America or wherever, and they can get a trial of the system usually. The way in which we train individuals is fairly well established. So the company have sales teams who will go on site to an individual center and train and educate the individuals on how to use the device so that they're confident. And then there's a post-treatment follow-up. All this training is free of charge, of course, and is fairly intuitive. I mean, being able to use the device is actually not that complicated. A lot of the complexity is taken out because the base station sort of effectively takes you through everything fairly easily. So that's the background to using it. It's hard to work out what might be the barriers in terms of implementation. We know dysphagia is a massive problem. We know that patients are desperate for treatments. We know that actually there are no really established treatments in the area that are life-changing, unfortunately. This is one tool. I think in the end, it's about being somebody who wants to try treatments that are potentially new but exciting. So we have people who are what we call early adopters. These are people who are really excited by these things and want to try them. And we have those who follow the kind of the crowd. And so it depends what kind of clinician you are. But we don't see any real kind of barriers other than the fact that there's some uncertainty as to who would place the catheter, because typically speech therapists are not trained to pass tubes. But of course, if they can do fees, then it's kind of basically in the same process. So one might argue that any trained therapist should be able to pass the catheter. Equally, I mean, there are many nurses, nutrition nurses who can pass catheters, pass nasogastric tubes, and they can pass the tube, and then the speech therapist can deliver the treatment. In the US, the model is slightly different. Some therapists can pass catheters, some rely on the medics to pass the catheters. But overall, it's about getting confident with the treatment, being happy with the clinical data, and then trying the treatment and seeing if you are convinced by the outcomes. And of course, in addition to adopting, there are usually published guidelines coming out all the time, guidelines from various organizations, whether it be in the UK, NICE, or Royal College of Physicians, or in Europe, there are a number of organizations, neurological organizations, and intensive care organizations who have already placed pharyngeal electrical stimulation in their guidelines. So the guidelines, I think, are very helpful. They, I think, give confidence to clinicians to use these things once the data has been reviewed and people are happy.
Yes, absolutely. And because you've just been talking about the early adopters, we think we have one of those early adopters in our next episode who's going to talk about the clinical implementation using PES in her clinical work.
I'll have to listen in.
Yes, absolutely. So maybe just as an outlook, what do you believe are the current gaps in the research on PES, and what future studies do you think we need to close these gaps?
That's an important point. I mean, one I've already touched on is other patient populations. We have increasing data in stroke and in various types of stroke. We have less data in traumatic brain injury, have less data in other forms of neurogenic dysphagia. So there are obviously needs potentially to increase our understanding in those other populations. That's one area. We probably will get some interesting outcome data from the FEAST study, the 800 patient. That will give us some hopefully very useful information about the populations within stroke who may benefit the most or benefit the least. And we'll also pick up more information about the treatment schedule, 3 versus 6 treatments, to see whether ultimately it's agreed that maybe 6 becomes the standard as opposed to 3 and then another 3. We probably need to understand a bit more about whether the combination of this treatment with other treatments is helpful. As I said, this is adjunctive, so patients are usually already receiving other forms of treatment, and this is added. But we don't know whether there's greater benefit, for example, when you deliver this treatment with certain behavioral therapies. And then there is obviously the intensive care population, which is seen as being a neurogenic population, but is generally kind of, I would say, ignored a little, really, and they can be very difficult to treat. There's a study actually going on in Europe, which is looking at intensive care related dysphagia. So there's lots of things that we still would like to know more about, and modeling how the treatment is ultimately delivered to the patient population. There's some interesting work around whether there's any effects on esophageal function in patients with dysphagia who have stimulation. Because, of course, the pharynx is not the only area that can be affected. And there are many patients who've got benign esophageal disorders, motility disorders usually, who have no treatments available. We don't know whether pharyngeal stimulation may be beneficial in those populations as well, because the nerve pathways are overlapping and there may well be some improvements in esophageal motility related to the stimulation.
To wrap up the episode, what do you think are the most important points about PES for you?
I think the first thing to recognize is that it is based on a lot of science over the years. So we have a large number of both preclinical and early stage clinical and then later stage clinical studies. So the science over time, the foundational science, has been developed right from the early stage through to the later stage. And I think that's quite critical because these studies take a long time. And without them, we just don't know what certain treatments might do or how they work. So understanding that process has been really quite critical. The other thing, I suppose, is the fact that when you think about the future of neuromodulation, so this is the whole concept of delivering neurostimulation to patients to improve their swallowing function. There are a lot of studies which are looking at different approaches to this. Some of them obviously using peripheral stimulation, but some of them using central stimulation. For example, non-invasive brain stimulation. What we probably need to understand is what ultimately will be the most pragmatic and effective form of treatment that can be delivered at the bedside. I would argue that as it stands at the moment, probably pharyngeal stimulation is probably the most straightforward to deliver in terms of its effects. There are still some complexities around brain stimulation, in terms of risks and difficulties and placement and everything. So I think pharyngeal stimulation is in a good place in terms of neuromodulation. And then obviously, as always, still need more data. There's always more room for more work. I think we need to look at other approaches, populations, differential stimulation parameters. But I think the future looks promising. I'm confident that we'll see increased interest and clinicians will become increasingly more familiar with the technique. And hopefully will feel that this is an extra tool in their toolbox that they can apply to help these desperate populations, really, these poor patients who have dysphagia, who are very, very desperate to find a treatment.
Yes, absolutely. It's a very optimistic outlook. I like that. Thank you so much, Shaheen, for taking the time and sharing your valuable knowledge with us today. It was a real pleasure. Thank you.
Thanks a lot. Thank you very much.
Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram @DysphagiaMatters, on Twitter @DysphagiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.